Okay. Hi, everybody. My name's Hillary Wright. I'm the Director of Nutrition for the Boston IVF Wellness Center. And before we get started today, I figured I would start with about a 25 or 30 minute that might answer some people's questions up front. And then we will have, a whole hour for questions. So I'm just going to share my screen with you. And I'm going to get going. All righty. So I thought I would start this presentation about PCOS by talking about a lot of the things that I've heard from women over the years. So maybe I should start with some background about myself. So I've been with Boston IVF for about 16 years. And prior to that, I was a nutritionist for Harvard Vanguard Medical Associates in Boston, where there was a reproductive endocrinology practice. So I was a nutritionist there, seeing patients from, beginning to end. And during that time, I was trying to conceive my second child. And I ended up being diagnosed with secondary infertility by a reproductive endocrinologist named Natalie Schultz, who worked down the hall from me after I was trying to conceive and it wasn't happening. I went down the hall and I said, I need you guys to try to figure out what's going on with me. So fortunately, after some minor hormonal tweaking and an IUI, I had my second child, and then I ended up with a surprise third child because I made some assumptions about my fertility, apparently, but not before going, not until after going through the workup. So I know about the blood tests and the dye studies and the biopsies, and I had all of that. So I have a very good understanding of what this process is like, including the stressors. So after my third child was born, Dr. Schultz asked me to start seeing her women with PCOS. So this was in 2000, February of 2000. I had no idea what the condition was, but I said I would learn. So I did some reading and I did some research. It was the early days of the internet. I was able to find another dietitian who was seeing patients named Martha McKittrick, who lived in New York. And long story short, I ended up learning a lot about PCOS, much of it through my patients. And the end result of that early on was the PCOS diet plan. This book is in its second edition. The first edition came out in 2010. It has green around the edge. This one came out in 2017. And the goal of my books is to try to help women with PCOS understand their body when they have this condition, because endocrinology is super confusing. And oftentimes women with PCOS are just told, lose weight and exercise, if they're even told that. So I, sadly, way too many times have had as patients women trying to conceive who were first diagnosed with PCOS when they were in their teen, adolescent years, and they were put on birth control pills and not really told much more than that. So since that first patient that I saw in February of 2000, I've seen hundreds of women with PCOS, maybe more. And I've heard a lot of things from them about women with PCOS, what their concerns are, what they need to know, and what stresses them out. And so some quotes that I got from some of my patients at one point: it's not just about fertility, it's about quality of life for me. The doctor stopped acknowledging the problem when I had my babies. The fact that we want our PCOS treated even if we aren't trying to conceive. Lean PCOS needs nutrition counseling too, not just for a prescription for metformin and birth control pills. Since losing weight can alleviate symptoms of PCOS, it would be nice to have the tools to do so, which is part of the goal of my book. Also, not to tell women with PCOS that it means they won't have a chance to have a child. I can't think of anything meaner than to say that to a woman. And my understanding is women with PCOS are considered good responders to assisted reproduction. And I don't know why somebody would say that to somebody else. Nobody is God. I also want the option of traditional and natural approaches when treatment is presented. I'm 49 and the reproductive endocrinology practice is done with me since I'm going through menopause. So PCOS is a genetic condition and it doesn't go away just because someone is no longer in the reproductive years. I'd like to be looked at as more than just an overweight body. This is a huge problem that I don't have to convince anybody about. I've actually had counseling sessions where my patient and I have sat down and constructed a script of how to talk to their physician about PCOS so that the focus doesn't always come back to the weight. That I'm overweight because of PCOS, not because I don't eat right or exercise. It's a huge misconception. And then truly listen. Many times I feel doctors aren't hearing the full story, and they've already categorized me based on my chart. So my role as a nutritionist is to help women understand this condition and figure out what they can do on their end through diet and lifestyle to contribute to the process, so it doesn't just feel like medical management without any ability to contribute. And in fact, diet and lifestyle management is considered the primary treatment for PCOS, targeting the insulin resistance, which we'll talk a lot about. So the first thing I do with my patients is I clarify the role of diet and lifestyle in managing that. Weight loss counseling and support, if that's what somebody wants. I always tell people I'm not here to tell you what to do. I'm here to listen to you and figure out how I can be sort of the tugboat to help guide you out of the harbor so you can sail on your own, but I don't have any preconceptions of what that looks like or how long that takes. Management of diabetes and cardiovascular disease risk factors, including gestational diabetes, of which women with PCOS are at higher risk. And then diet and lifestyle counseling support around overall health and fertility. So I don't ever look at my patients in a microscope just around the fertility piece. Of course, I want to help my patients build their families, but I also don't want them to have diabetes and some of the other things that come along with PCOS. So what is polycystic ovary syndrome? First of all, the first thing I should say is it's actually a very badly named condition, because it makes it sound like the cysts and the ovaries are what's causing the problem, when really ovarian cysts are a side effect of the metabolic problem that's going on behind the curtain with this condition. So this condition, we've known about it for over 100 years. You know, first they called it bearded lady syndrome, talk about not sensitive back in the early 1900s, maybe even prior. Then it was called Stein-Leventhal syndrome after the first two physicians who started to piece it together, and then became polycystic ovary syndrome. So there is a movement to try to change the name to make it more reflective. And in fact, you don't even have to have cysts in your ovaries to be diagnosed with PCOS. But the Advocates PCOS Challenge is an amazing advocacy organization. So anyone who has this condition, I would definitely encourage you to check out PCOS Challenge. They and others are not on board with the name change because it's taken us so long to get people to recognize this condition by this name, that if they change the name, my last heard, the strongest contender was metabolic reproductive syndrome, or MRSS. You know, it's back to square one with the advocacy. So anyway, what we call polycystic ovary syndrome is the most common disorder of women of reproductive age relating to endocrinology. So endocrinology is the study of hormones. And in this condition, women's reproductive hormones are often affected. Estimates are anywhere between 8 and 20% of women. The reason why the statistics are so waffly is because there's a lot of women who are undiagnosed with PCOS. And it's under-researched. So I've done several years of advocacy with my legislators in Washington, D.C. around this condition. And I learned this year that 1% of the NIH, National Institutes of Health budget goes specifically to women's health issues, but something that's half the population, and a fraction of that goes to PCOS. So we all have a lot of work to do to kind of really push for more research. We do know that PCOS is the primary cause of anovulatory infertility, so infertility related to not ovulating. The hallmarks of PCOS are hyperandrogenism, so that's the elevated testosterone piece, and chronic ovulatory dysfunction. So women with PCOS may either have no regular periods at all or inconsistent irregular periods. But upwards of 70% of women with PCOS are insulin resistant. So we're going to talk about this a lot. And this insulin resistance occurs irrespective of weight, meaning it's also present in lean women with PCOS. It's just that the symptoms are worse if a woman with PCOS is struggling with her weight in addition. So in order to understand PCOS, you have to understand the function of insulin. Insulin is the largest growth hormone in the body, so it is a hormone. And it actually evolved in humans, the action of insulin, to help human beings survive droughts and famines. So in that function, we call it an anti-starvation hormone. So PCOS, as well as diabetes, heart disease, high blood pressure, all the way down to flat feet. There are many, many modern health conditions that are considered genetic mismatches. So we all carry with us genes. Evolutionarily, our body still thinks we're kind of Stone Age people. So we all carry around with us genes that were favorable throughout most of history that are backfiring and causing a lot of health problems, given that our environment has changed radically since the early 1980s. So I've been an adult all that time, and I've witnessed how much the world has changed, and that's nothing in terms of evolution. So insulin as a hormone regulates the metabolism of carbohydrates, fats, and proteins. So it's not involved in fat absorption and utilization, but it can encourage fat deposition, which we'll talk about. Insulin is a little involved in protein metabolism, but overwhelmingly it's most tied to the metabolism of carbohydrates. So its primary function is to assist with the transport of glucose, or blood sugar, from the blood into our liver, fat, and muscle cells. So the bottom line is insulin is a storage hormone. When we eat carbohydrates and glucose shows up in our blood, and the pancreas secretes insulin in response to that, the insulin is running around and unlocking our cells and making our cells grow. But in this anti-starvation capacity, insulin does not like to waste calories. And that's how it gets around to encouraging fat storage, particularly in the abdomen. And we'll get into that more in a few minutes. But basically, because insulin is an anabolic hormone, as long as someone has higher than perfect circulating levels of insulin, they're likely to be in calorie storing mode. The problem is the way we test this is we test blood sugar levels is the primary way to test for insulin resistance. So that would be a fasting glucose test, an oral glucose tolerance test, which is when you drink this goop, really sugary goop. Anybody who's had a test for gestational diabetes knows how nasty that is. You fast, you drink the goop, they test your blood sugar an hour later. Or much more commonly I'm seeing is they're using hemoglobin A1C levels to diagnose insulin resistance. So a hemoglobin A1C kind of estimates what your blood sugar has been for the past 3 months or so. The thing about all of those means of testing is they don't tell you if you have insulin resistance, period. They tell you if you've had insulin resistance for long enough that it's starting to affect your blood sugar regulation. So everybody with type 2 diabetes, for example, which is the most recognized form of insulin resistance, type 2 diabetes is insulin resistance that's kind of evolved all the way to that point. Everybody with type 2 diabetes prior to that had blood sugars bumping up that were not high enough to call diabetes. We call that prediabetes. But everybody with prediabetes had a period of time prior to that where they were insulin resistant, but their pancreas, which is the organ that makes insulin, was youthful and energetic enough to just make extra insulin when it encountered insulin resistance. So we do sometimes test fasting insulin levels, and some of you may have had those. The problem is it's not considered a standardized test, meaning if you go to any lab in the country and ask for a fasting glucose test or a lipid cholesterol profile, you're going to get basically the same result, or the same assay and the same kind of normals. That is not the same with insulin levels. So sometimes they're glaringly abnormal, but sometimes they're not. However, it's not considered fully conclusive as to whether somebody has insulin resistance. So the general consensus, there's 3 different organizations that have kind of agreed to agree that signs of hyperandrogenism, so those are the ones that cause a lot of the physical symptoms that make people crazy, excess facial hair or hair growth in other parts of the body, thinning of the hair on the crown of the head, acne, particularly cystic acne in some people, cholesterol profiles that look kind of more like an older man than a younger woman, all related to these androgen male type hormones, testosterone being the predominant one. And then some signs of irregular periods. If you have those 2 things, you could classify for PCOS, even if you have no cysts on your ovaries. Conditions that need to be ruled out are Cushing syndrome, thyroid disorders, congenital adrenal hyperplasia, and hyperprolactinemia. And they test for all those things when you have your fertility workup. So the symptoms, I don't need to tell all of you. menstrual irregularities, amenorrhea is no periods, oligomenorrhea irregular, or sometimes is bleeding without ovulation or very heavy periods. So I've had women with PCOS that bleed all the time to the point where they need iron supplementation. Infertility, obviously hirsutism, that's the excess hair growth, acne, weight struggles, especially around the waist. But though we do know that there is a subset of women with PCOS that have what we call lean. I suspect there's more than lean PCOS and women who struggle with their weight. Maybe years from now we'll be, swab your cheek and figure out what kind of variant you have. But we know that there are some differences between women. Pelvic pain, oily skin, acanthosis nigricans is that darkening of the skin around the base of the neck and around the armpits, and also a lot of skin tags. Okay, so what about weight and PCOS? So this is another super waffly statistic. Reported, this says 50 to 80%. I've seen 30 to 80%. The problem with trying to figure out this statistic is that women who have PCOS who also struggle with their weight are more likely to be symptomatic, more likely to have irregular periods, and more likely to go to the doctor, and therefore more likely to end up in a research study. So increasingly, we're starting to realize there was one large study that was done where it was in Australia or England or somewhere, where women who were going through pre-employment physicals agreed to be screened for PCOS. And what they actually found in that study is that women with PCOS who classified didn't necessarily weigh more than other people. Now, a lot of people would definitely disagree with this, and we don't. There's no question that it can make weight gain easier and weight loss harder, but actually putting a number on the rates is a problem because the excess weight creates more symptoms and therefore more diagnoses. Women with obesity and PCOS are more insulin resistant as a rule, and therefore greater risk of diabetes, more likely to have higher levels of testosterone, so more likely to have many of the hyperandrogenism symptoms. But the good news is losing as little as 5 to 7% of weight may be enough to return ovulatory function, reduce the hair growth and the acne. And this is often best achieved by focusing on managing insulin resistance to reduce risk of diabetes and improve fertility. And a lot of the research that you look at and weight and IVF and PCOS finds that what pops the most that I've seen is higher rates of natural conceptions. And I actually have 2 women with PCOS right now who, after losing a certain amount of weight, they both became pregnant without actually thinking that they were trying. So if you have irregular periods and you're increasing your activity, eating healthier, maybe not, weight is part of that, and you start ovulating at some point, you could conceive. So any woman with PCOS who's trying to conceive or not actively trying to avoid it should make sure she's at least taking a multivitamin to get the folic acid we want really present in early pregnancy. Obviously, I'm also very vested in reducing the risk of cardiovascular disease and diabetes in particular. We know that this excess belly fat that is common in PCOS increases inflammation, which can increase the risk of both of those conditions. I already mentioned cholesterol profiles may be an issue. High total and LDL cholesterol, low HDL cholesterol. So LDL is lousy for you. You want it to be as low as you can get it. HDL is healthy for you. You want it to be as high as you can get it. And then high levels of triglyceride, that's the fat in the blood. But very scarily, from my perspective, estimates are that 50% of women with PCOS will have prediabetes or diabetes by the age of 40. This is largely a preventable condition. So and beyond the fertility thing, we all need to be very vested in diabetes prevention. So in terms of screening for diabetes, the Androgen Excess Society recommends that every other year, any woman with a PCOS diagnosis has an oral glucose tolerance test. I actually don't see a lot of women with PCOS having oral glucose tolerance tests, but it may be the most effective way to pick up prediabetes in women with PCOS in particular. One large study suggested that fasting blood sugars and hemoglobin A1Cs were definitely diagnostic as any other test for diabetes, but that prediabetes was more likely to be picked up in an oral glucose tolerance test. And then women with obesity and PCOS are at greater risk of gestational diabetes. So any woman with PCOS who conceives should have an earlier first trimester glucose tolerance test. Another emerging concern that we're just starting to pay more attention to in the population in general is a condition called NAFLD. It's non-alcoholic fatty liver disease. It's the most common cause of liver disease in the Western world, not related to alcohol, estimated in general to affect about 25% of the US population and more than a third of women with PCOS. So this was in a study where the mean BMI was 29.5 and the mean age was 24. So we're seeing a lot of non-alcoholic fatty liver disease in pretty young women with PCOS. Women with PCOS and others should have their liver function tests monitored. But again, the same very reasonable amount of weight loss, 7 to 10%, and managing the insulin resistance is the best thing for NAFLD. And again, I don't need to tell anybody here about the trials and tribulations emotionally of PCOS. Loads of studies identifying depression, anxiety, body image issues, eating disorders, particularly compulsive overeating and bulimia, very common. But, let's list the reasons why. Hormone fluctuations, blood sugar fluctuations, loss of feminine identity, infertility stress, weight issues, fear of chronic disease. I mean, take your pick. There's a lot of reasons to feel stressed when you have PCOS. So when it comes to fertility, I know that's what a lot of people are interested in. When you really drill down, and I'm going to do a little mini fertility hormone thing with you in a minute. When you really drill down on the hormonal communication that needs to occur in a cyclical, consistent month-to-month manner via this ovarian hypothalamic pituitary axis, in order for potentially an egg that can potentially fertilize each month, the continuous hormonal communication has to occur as like a miracle of like nature, God, whatever you believe in, that it works as often as it does, because it's very complex. We now understand, again, we're going to talk a lot more about insulin, but excess insulin secreted to overcome insulin resistance in muscles, well, it's a hormone, and it's going to go all over the body and exert its influence. Increasing androgen levels are related to insulin levels. Interrupting ovulatory hormone communication. High levels of insulin are also not great for egg quality. So understanding PCOS requires understanding insulin resistance and its many functions. So I already gave the statistic, 70 to 75% of women with PCOS and obesity have insulin resistance. But up to 30% of women with lean PCOS also have insulin resistance. I've seen women who are thin, who don't get their period, who have facial hair, who have acne, and are struggling with infertility. And oftentimes I think they're the ones that probably get ignored the most, because a lot of people, including clinicians, still think you have to have obesity to have PCOS, and you don't. So we already kind of touched on this. Insulin is a hormone produced by the pancreas that unlocks our cells like a key after we eat carbohydrates, so glucose can move out of your blood and into your cells to be used as fuel. So when we eat carbohydrates, the sugar shows up in the blood about 60 to 90 minutes later, at which point the insulin tries to sweep it out of the blood and into the cells. The thing is, the cells are only going to take on what they need for fuel during that post-meal period of time, and then they're going to lock the door and not take any more in. So insulin, in its anti-starvation, survive the famine for our ancestors function, will say, okay, I've moved all the glucose I can get out of my blood into the cells, but I don't want to waste it because a drought or a famine may come along. Insulin has this ability to convert glucose into triglycerides, which is fat, and store it, and it really likes to store it in the abdomen. So we call that belly fat. It's called visceral adipose tissue. And this kind of fatty tissue is not so much between the abdomen and the skin. It's more from under the muscles around the liver and the intestines. And so the thing is, it can become like a vicious cycle, because this fat deposition in the adipose region can aggravate insulin resistance. So because insulin is a fat protecting hormone, ultimately, it literally, as long as we have higher circulating levels of insulin, it kind of stands outside our belly fat like a guard and says, I'm keeping it. You can't have it unless you give me a really compelling reason. This was great for us cave woman ancestors, not so great now. So in order to liberate body fat, we need to get insulin levels into a healthy range. So I go into a lot more detail with this graph right here with my patients, but basically this is insulin resistance. We eat carbohydrates, sugars show up in our blood about 60 to 90 minutes later. So we always have to have some sugar in our blood. Now more sugar shows up, directly proportional to how big was the portion of carbohydrate you just consumed an hour ago. So if somebody has, a sub and a bag of chips and a soda, their blood sugar is going very high. They're going to need a lot of insulin to sweep that out. If someone has, a sandwich on whole grain bread with some protein, a seltzer, and, a piece of fruit or whatever, it's not going that high. So it's definitely proportional to what was consumed. Our pancreas reads our blood sugar right after the sugar shows up in the blood and secretes insulin out into our blood that goes around and basically unlocks our cells by hooking up with these basically keyholes for insulin. They're called insulin receptors on the cells. There's hundreds of them there. All it needs to do is find one and connect. In insulin resistance, these receptors are resistant to the action of insulin. So that's where that term comes from. It's like the insulin tries to unlock the cell, but the cell is sort of numb to the action of insulin. The pancreas is always rechecking our blood sugar. So what it will do in response to that is secrete more insulin. So in insulin resistance, the cells resist being unlocked by insulin. So the pancreas response is to release more to force the cells open. But the result is a strain on the pancreas, which over time can tucker it out and increase the risk for diabetes and these higher circulating levels of insulin that are cause inflammation and encourage the deposition and storage of body fat. So this is the hypothalamic pituitary ovarian axis. I'm not going to get into the weeds on this, but the bottom line is a potentially fertile cycle starts with eggs that 2 to 3 months prior to ovulation, eggs, kind of start to mature in follicles that hopefully at least one will make it to the finish line 2 or 3 months down the road, a genetically healthy egg that will pop out its ovulation, hook up with a genetically healthy sperm, travel down a fallopian tube that's open, land in the lining of your uterus where it's thick enough to absorb a fertilized embryo. This all requires this continuous hormonal communication between the ovaries, the hypothalamus, and the pituitary. This is hormone communication. So if you have that blood sugar stuff I was just describing with extra insulin being produced to regulate that, well, that extra insulin can throw a wrench into this communication, causing periods to either stop or become irregular. So we're trying to, again, get insulin levels down to a healthy level. So common complaints I hear from women with PCOS: fluctuations in energy level throughout the day, frequent hunger, not feeling satiated for long after eating, binge eating at times. I hear a lot of talk about being addicted to sweets. And when I talk, kind of dig through that with a lot of my patients, a lot of what we're unearthing is, often consuming too many refined carbohydrates that causes insulin levels to fluctuate wildly along with blood sugar levels. And when blood sugar levels drop, cravings for sugar go up. So the goal with the diet and lifestyle therapy is to get our blood sugar and our insulin levels to roll like hills over the day by regular eating, paying attention to the types of carbohydrates we're eating enough protein and healthy fat, and not going too long without eating. Because we all know anybody who goes too long without eating, when they get around food, will likely overeat. People with insulin resistance, often it feels more urgent. When they get over hungry, they're literally feeling hypoglycemia or low blood sugar, which just raises cravings for carbohydrates and just keeps the cycle going where blood sugars are actually rolling like mountains and valleys, spiking and dropping like mountains and valleys, not rolling like hills. Irritability or hangry. I get hangry for sure. I hear a lot of hangry talk. And then often severe intolerances to very low calorie diets, particularly very low carb diets. So in my 22 years of seeing women with PCOS, I've seen tons and tons of misinformation. This condition is highly subject to misinformation on over-restrictive diets. Gluten-free, dairy-free, keto. What a lot of people say they're on keto, they're actually often on Atkins. So they're not so much, they're eating enough protein, but really, really driving the carbohydrates down, or very low carbohydrate diets. It's really important for people to appreciate that the human body likes carbohydrates. They're not all bad. There are whole foods-based carbohydrates, fruits, vegetables, whole grains, milk, yogurt, things with a lot of good nutritional attributes. Then there are refined carbohydrates, candy cakes, cookies, ice cream, soda, white flour things, white rice. They're not toxic foods. They're foods for fun. Enjoy them sometimes, absolutely. But when you take a carbohydrate from nature and you process it into another food, you're removing the fiber, which is one of the elements that can actually slow down blood sugar absorption and help our blood sugars to roll, as well as a lot of the healthy nutrients are removed. Many of my patients have very long histories of failed weight loss attempts, weight cycling, also known as yo-yo dieting, and will often report that weight loss is more difficult, which is easy to understand with this anabolic state that we've been discussing. Eating disorders, very common. 11 in one study of over 8,000 Australian women. These were present in 11% of women with PCOS versus 7.6% in the general population. And then carb cravings, binge eating is common, likely due to the high insulin. You know, when your blood sugar surges, your insulin runs right up after it and knocks it down. And that's just going to increase the cravings again. Body dissatisfaction, of course, very common. Stress eating, you know, when they do research on people who lose weight and maintain a meaningful amount of the weight loss, when they look at those folks, this is part of the National Weight Control Registry, and I talk about this all in my book. When they look at things that correlate with a higher risk of regaining the lost weight, stress eating is way up on the top of the list. So there's often some emotional therapy that needs to go on to help people kind of make some peace with their relationship with food. So what's the best diet therapy for PCOS? There is no giant consensus. However, there are some good indications that a diet that is a little higher in protein, so healthy kinds of proteins, seafood, poultry, some lean meat, not protein at any cost, not fats at any cost, you know, heart healthy fats make a difference in terms of how sensitively your body uses insulin. Lower carb diets, not low carb diets. So there is some evidence that these are useful in managing weight, improving metabolic problems like insulin resistance, high cholesterol, high blood pressure. But I find that I try to really avoid diet talk because I don't believe in over-restrictive diets. I've lived long enough. I've actually been a dietitian for 34 years, and I've seen many trends come and go. And we still in our culture have this approach that if I do this over-restrictive thing for a period of time, then somehow I'm going to figure out how to transition out of this and keep the weight off. It's not to say past experiences don't have some value, though. So in the National Weight Control Registry, the people who are more likely to maintain a significant amount of the weight loss after the fact, they learn skills from their previous weight loss attempts that eventually allows them to come up with their own sort of portfolio approach of all the things that they learned from the past. So, example, if somebody did a weight loss experience with shakes and it didn't result in lasting loss, then maybe they won't reinstitute that approach. If going to the gym at 5 o'clock didn't work before, maybe it won't work again. Protein is more satiating, meaning it fills us up faster, keeps us feeling fuller longer than carbohydrates, and helps preserve muscle mass during weight loss. So on average, about 25% of the weight people lose when they go through an intentional weight loss episode, about 25% of it is muscle. Research is now telling us that if we strength train, push on our muscles through the weight loss experience and eat enough protein at regular intervals throughout the day, ideally at least 20 grams of protein per meal, some people might need more, that can help to mediate some of the muscle loss. But what's clear is whatever you do with diet and lifestyle has to last because temporary change yields temporary results. And research does not support high protein, low carb diets, which may be high in animal fat and promote binging due to low blood sugar. So it's not ever to say that there aren't people that find these experiences beneficial. It's just that we have to try to focus on long-term what is going to last. But again, the good news is from a fertility standpoint, studies suggest even modest weight loss improves fertility in PCOS by improving insulin resistance, lowering circulating levels of insulin that can disrupt reproductive hormones. So again, that's like 5 to 10%. So if someone weighs 240 pounds, if they lost 12 pounds, it may be enough to make their fertility outcomes improve. But weight loss is hard. We know that. So even without significant weight loss, women with PCOS will follow an anti-inflammatory plant-based diet, will be healthier and feel physically and emotionally better. So I always encourage my patients, and I know it's difficult, to try not to hook the healthy eating and exercise caboose to the weight loss train, because we don't know what that's going to take. And if we only use that as the judgment as to whether what we're doing with diet and lifestyle is valuable, we often miss out on all the other things that healthful eating and physical activity does to make us feel better in our body. But overemphasizing weight loss can pummel self-esteem. Again, we all know that, and that can actually impair someone's ability to appreciate the other benefits that may, in the long run, make weight loss possible. So I really like to dress this whole conversation up in a different outfit. Let's manage the insulin resistance and see what happens with the weight. Because we know that diet and lifestyle, whether we're talking about just good health or weight control, it's very synergistic. It's emotional health, food activity, weight control, sleep. Sleep is really important. Being sleep deprived raises stress hormone levels that can make weight gain easier and weight loss harder. So please don't underestimate the importance of aiming to try to get at least 7 hours of sleep as often as you can. So how do I work with my patients? And these principles are all outlined in my book. I let the patient guide the process. It's not my life, it's their life, but generally it involves education on the role of diet, physical activity, and other lifestyle factors in managing PCOS and insulin resistance. So weight loss, however it's achieved, is going to improve people's hormones when they're on PCOS. However, I ward strongly against crash dieting prior to fertility treatment because there is evidence to suggest that that may be detrimental. And it makes sense to me. If someone's trying to conceive, why do we want to tell their body they might be starving? Okay, our body has a lot to say as to whether a particular point in time is a good time to try to have a baby. And starving prior to conception may actually backfire. On the other hand, there's sufficient evidence that exists that moderate carbohydrate, plant-based, so high fiber, whole foods-based, low in added sugars, a little higher in protein, heart healthy fats without extremes is beneficial. And do know that, so even the dietary guidelines for Americans says, if 85% of the calories you're eating are coming from foods that are doing your body good, it doesn't really matter what the other 15% are doing. So I'm sure we'll talk about this in the Q&A. Individual foods don't turn your health on and off like a switch in any aspect. The exception being severe allergies. An individual food may exert a health outcome. But individual foods don't improve fertility or impair fertility. It's the dietary pattern. I talk a lot about carbohydrate distribution. Over the day, carbohydrate paired with protein, when you're hungry but not starved, can go a long way towards getting your blood sugars to roll. What I see is an extremely common pattern in this country is we don't eat enough during the day and then it backfires at night. So women are really good dieters until about 4:30 in the afternoon. And then your brain's decided it's had enough, and we tend to overeat at night, or we're just so busy that we don't take time to eat. Is it any wonder that we then overeat when we get around to it? But carb distribution is much more important than total carbs. Pairing carbs with protein, like I said, makes satiety better. Physical activity, I'm going to talk about in a minute. And then there are roles for sensible supplementation, multivitamins, vitamin D, myo and D-chiroinositol. We can talk more about that in the Q&A, I'm sure. CoQ10 are the most common. Lean protein is key, so not fatty cuts of meat, aiming for 20 to 25 grams of protein from seafood, poultry, lean cuts of meat. Lean meat has the word loin, round, or flank in it, or is 90% lean or leaner, including plant sources of protein like tofu, soy things, nuts, legumes, quinoa. And plant protein may actually benefit fertility. So this is that rolling hill pattern that I was talking about. If you have a carbohydrate that has its fiber complicates digestion because we can't absorb it. It stays intact through our GI tract. So when we eat whole grains as opposed to refined grains, that fiber, our intestines, our digestion has to sift through the fiber to get at the sugar so it more gradually goes into the blood. If you then eat it with protein, a little healthy fat, it makes your blood sugar rise more slowly. The slower it rises, the slower it falls. So I talk a lot in my book about the balanced plate approach. Every health organization that has a healthy eating plate infographic. So these look simple, but these are infographics that have a ton of science embedded in them. This is what the old food pyramid got tossed out probably 15 years ago and replaced with this choose my plate. This is the Harvard healthy eating plate. These are basically a Mediterranean diet, which is what this pyramid is, on a plate. So when I am educating people about this balanced plate visual, it's not just a dietitian's idea of what healthy eating looks like, because this is how we like to eat. This is what the science tells us for lowering the risk of pretty much every chronic disease you can think of per meal and snack carbs for people that want to get into the weeds with grams. I don't take that approach up front, but I do give people that information who want it to pair it with their food logging apps or read labels. Somewhere between 30 to 60 grams of carbohydrate or so per meal, 15 to 30 with snacks. So there are also, so the last little bit, a lot of concerns about things like soy, dairy, and gluten. There's actually research to suggest that women with PCOS who eat soy may actually have improved reproductive outcomes and improved cholesterol levels. Plant proteins are good for health on many levels. The phytoestrogens and soy foods. Phytoestrogens are plant estrogens. It's not estradiol. I work at Dana-Farber Cancer Institute in Boston part-time. I talk to breast cancer patients about this all the time. Women with breast cancer, estrogen receptor positive breast cancer, studies tell us that if they eat soy foods, they don't do worse. So they may actually do better than women who don't eat soy food. So these do not shift. I think I've seen one woman in all my years, and she was eating a lot of soy protein isolates and protein powders and artificially concentrated sources of soy. Dairy may potentially be a player in acne. And we could use more research on this, but there is by no means research that tells us that women with PCOS can't eat dairy. If cystic acne is a big issue, and this is true whether or not someone has PCOS, acne may potentially respond to removing dairy products for 2 to 6 weeks and see if it gets better. Some people may choose to limit it to a couple servings a day, but this can provide a really important things like yogurt, cheese, and milk can provide important sources of protein. And again, gluten, there is no science. I've looked again. There is no science that says that women with PCOS are more likely to need a gluten-free diet than other women. They may have celiac disease and PCOS, and people have wheat intolerance, people have gluten intolerance without having without having celiac disease. And so those could still be present, but there isn't science that specifically tells us that. And then this last little bit of exercise improves insulin sensitivity. Insulin is supposed to just unlock our cells, and inside the cells are supposed to be proteins that run to the surface of the cell and pull the glucose out of the blood. But those proteins are produced as a result of physical activity, which is why diabetes was a rich person's problem 100 years ago. Exercise is critical for insulin sensitivity and taking the pressure off your pancreas, mobilizes belly fat, reduces cancer risk. So you may read about women with PCOS having increased risks of endometrial cancer. Exercise is good for that, as is making sure you have periods at regular intervals, which would reduce the likelihood of the lining of your uterus growing out of control. So the recommendations are at least 150 minutes of moderate physical activity a week, but for people that are very vested in weight management, it may be as high as 300 minutes a week, which is an hour, 5 days a week. All exercise guidelines recommend strength training at least twice a week. So how do you know it's working? When you incorporate some of these changes, you feel better, you have more energy. People commonly report more energy. Maybe your cholesterol numbers, A1Cs improve, prediabetes reverses, emotions feel a little less labile. People may feel more in control of their cravings and feel more like this is something I can have an influence over. More consistent ovulation, more natural conceptions. And you notice I have weight loss way down the bottom of the list. Yes, any amount of weight loss is going to improve insulin sensitivity, but whether or not somebody loses weight, there is going to be an improvement in your health in many ways, regardless. So I know that was kind of a lot of information. These are just my 3 books. I also co-wrote one on menopause with my best friend from college and one about diabetes prevention. So I'm just going to now just hit the ground running with some of these questions. So I'm going to scroll up. Okay. Okay. Can PCOS be on a spectrum? For example, a lean person with regular periods but excess hair and hormones consistent with PCOS? Absolutely, yes. There's clearly a lot that we don't know about this, and I'm sure that we might have different things to say about it years down the road. Should you alter your diet based on the phases of your cycle while trying to conceive? I know that this information exists on the internet. I've never seen any science to back it up, and I don't understand how it could, because again, individual foods do not immediately affect your hormones like a drug. So it's the dietary pattern. This plant-based eating pattern is very consistent with dietary patterns that associate with better fertility treatment outcomes. And so plant-based eating throughout, I had a patient tell me that she read something that if you eat avocados during a transfer, is how she put it, during a transfer. And I had this visual of somebody like with, feet in the stirrups, eating an avocado, that you are more likely to have a positive outcome. It makes no sense to me. She and I Googled it together. I found the line on the internet, and of course, there was no research study attached to it. Is there an overlap of foods to eat to improve egg quality and reduce? Yes, definitely. Egg quality is plant-based eating. So again, whole grains. So whole, when you're buying bread, cereal, rice, I have all the stuff in my book, crackers, you want to look for the word whole in the first ingredient. That tells you it's a whole grain bread or cracker. Whole fruit as opposed to a lot of juice, vegetables, seafood, not drinking a lot of alcohol, not smoking too much pot. All of these things are good for both egg quality and insulin resistance. How long of following this diet does it take for positive effect? It's, again, that's going to be an individual. How long does it take for somebody to experience changes in their fertility? It really depends on the individual person. If weight loss is part of their plan, the two patients that I have that naturally conceived, both were at it for about, again, this is just their experience, for about 6 months or so. But I say there's no better time than the present. I've heard PCOS can also lead to higher miscarriages. I believe that is true. I'm not a doctor, but I believe that is true. And I do see research suggesting that it may be worth continuing inositol during pregnancy to, hopefully reduce the risk of miscarriage, possibly influence gestational diabetes risk, though I think that that's still kind of being looked at. I don't have concerns about women taking inositol during pregnancy, though I do encourage them to take an NSF certified type of inositol. For example, ovasitol, which is very commonly talked about in the PCOS community, it's in this 40-to-1 ratio of myo-inositol to D-chiro-inositol. So you get either these little packets or a container with a scoop, and that serving is 2,000 milligrams of myo-inositol and 50 milligrams of D-chiro-inositol. The recommendation is to take it twice a day with meals. Their product is third-party certified by an organization called NSF. So it's important to understand that dietary supplements are not regulated by law. So I take great consolation in knowing that a product that my patient is taking has been independently analyzed and I know what's in it. Can a better diet also control cholesterol, fatty liver disease, prevent diabetes? Yep, it's all the same thing. That balance plate thing, there's not like 5 different diets for 5 different things. This balance plate visual is a moderate carbohydrate, adequate protein, high fiber, diet high in fruits and vegetables, with healthy fats. All of that is the same, whether you're trying to manage insulin resistance or improve your heart health. Okay, do leaner, regular BMI women with PCOS still benefit from weight loss? No, so if you're at a healthy weight, I would not encourage weight loss if you're trying to conceive, because in my opinion, there's been enough research studies to suggest that weight loss dieting prior to IVF can be counterproductive. The problem with a lot of these studies is they don't flesh out enough. Like, what are you talking about, a weight loss diet? If somebody's starting to eat healthier and getting rid of a lot of added sugars and refined carbs and prepare their own meals and eating out less and all of that, as a result of that, they're kind of gradually losing weight. I don't have a problem with that. I think that's a good idea. But I do think extreme attempts, and I understand how this can happen, particularly if your insurance company or your reproductive endocrinology practice is telling you that you have to lose weight prior to IVF. My heart bleeds for that situation, because I just think it's brutal and it's hard, and it puts an inordinate amount of pressure on somebody. So if someone doesn't need to engage in that weight loss, I would just focus on healthy eating and managing insulin resistance. So I guess if you're already in a healthy weight range, being thinner, is that better? And I would say just eat healthy and see where you just stay in that healthy range. Do you recommend prebiotics or probiotics, such as the brand Seed, and do they impact fertility? So the more I feel like the more we learn about probiotics and the microbiome, which is the kind of the healthy bacteria that lives with us. Like, as weird as it sounds, we've got like 3 or 4 pounds of healthy bacteria that coexist with us in our intestine, the vast majority of it in our colon and our large intestine. And it lives with us because it provides an important service in support of our immune system. So this healthy bacteria, which so they say what makes this a complex issue is this healthy bacteria, this microbiome is unique to an individual as their fingerprint is. So a lot of the stuff about probiotics talks about like kind of it's like this one thing. So it's not. So the more we learn about probiotics, the more I feel like we have so much more to learn. So if somebody has something they're specifically trying to target and they want to take a probiotic, you know, there's an online tool called the US Probiotic Guide that anybody can access. And you could go in there and you could look at the actual research on different kinds of probiotics by brand name. So there are some that are targeted to specific conditions, like antibiotic use. I've not seen consistent evidence to suggest that probiotics correlate with improved fertility outcomes. Because again, I think it's just a complex issue that whenever you're trying to study one aspect of somebody's diet, you have to control everything else that could potentially affect that outcome. And that's why nutrition is such a hard thing to study. So this is a very roundabout way of saying, I'm very in favor of people eating probiotic foods, yogurt, kefir, kefir, how you pronounce it, kimchi, kombucha, as long as it's not loaded with sugar. Those are full of natural probiotics. I think that's a good idea. Prebiotics are dietary fiber. Goes back to the plant-based eating. So the probiotics eat the prebiotics and make these compounds called postbiotics, which are the things that quell inflammation and oxidation and lower our risk for diabetes and heart disease and colon cancer. So I'm much more in favor of probiotic foods and high fiber diets. Should you have your own, why should you have on your team to help, who should you have on your team to help navigate a new PCOS diagnosis? Definitely a physician who's skilled and sees a lot of these patients, whether it's a primary care doctor, a GYN, reproductive endocrinologist, that's willing to see women who are not going through fertility treatment, a therapist if you're really struggling, and of course, I think a dietitian, a registered dietitian who's knowledgeable in this area, because it is considered the primary treatment. Do I ever see patients who need to gain weight in order to increase the change? Absolutely. So in the most extreme, there's a condition called hypothalamic amenorrhea. So your hypothalamus is the part of your brain that is like the survival manager of the human body. And the hypothalamus is constantly putting feelers out into the world to try to decide, is there a stressor going on out there that I need to adapt to in order to survive? Because remember, our body, our body still thinks we're Stone Age people. If the hypothalamus thinks there's too much competition for calories, it may shut down your reproductive function. And that often occurs because someone's exercising a ton and not eating enough. So for example, we know that hypothalamic amenorrhea is not uncommon in women who are competitive athletes who need to manage their weight. So calories are important. You know, if you're trying to conceive, you're trying to tell your body this is a well-nourished place, there's enough calories, there's enough protein, there's, you know, not too much physical activity. And so women who have that condition sometimes have to eat 2,500 calories for 3 to 6 months with doing not a lot of activity in order to start getting their periods again. So that's in the extreme, but I do see women who, from my perspective, are kind of clean eating and exercising a ton, but not eating enough calories and protein. And even if they still are getting their period, I would work with them to try to get them better nourished. And that often involves weight gain. I'm on the border of getting prediabetes and cholesterol and had to make major changes to my diet. How can you eat healthy food that tastes good? You know, taste is, I of course think healthy food tastes good. I credit my mother for that because I grew up in a family with 5 brothers and sisters, 2 of whom had type 1 diabetes. And we sat down to meals that were healthy. You know, they had to be because I had 2 brothers with type 1 diabetes. And that's the food we ate. And that's, you know, through my life is what's tasted good to me. I can't tell somebody what it's going to taste good to them. All I would say is that sometimes people decide what they like and they don't like really early in life and they never try again. And my feeling is if you're still alive, you're not too old to try new foods prepared a different way. So for example, if your, you know, childhood experience were vegetables that were overcooked and they were gross and you didn't like them, well, maybe try salads, try roasting vegetables, put vegetables in, you know, tacos and wraps and incorporate them into things and into soups, but just don't ever give up. Just keep trying and, you know, try out vegetables and fruits that you have access to at other people's homes. Just keep trying, but the taste thing is very individual. So there's really no diet that helps with PCOS, just portion controlling and limiting carbs. I struggle with weight loss and PCOS, so I'm trying to find something that works. So there is, so again, it's a plant-based anti-inflammatory diet, which is a Mediterranean diet, or there's other diets. There's an organization online, they're actually based here in Boston, called Old Ways. The website is oldwayspt.org. They have African heritage diets, Asian heritage diets, you know, a lot of Latino culture diets, where there's a lot more emphasis on plant foods. So plants, let me talk about why this matters. So we know that PCOS is a pro-inflammatory condition, it's associated with a lot of inflammation, as are other chronic diseases like diabetes, heart disease, cancer. We know that plants, fruits and vegetables, besides being low in calories, because they're mostly water, so they help to fill us up without loading us down with a lot of calories, maybe make it easier to not eat that extra pork chop or that extra portion of starchy food. So there's just that filling up on something low in calories. But the actual components in plants have a medicinal effect to the human body. Dietary fiber, as I mentioned, feeding the microbiome. The microbiome produces compounds that quell inflammation, quell oxidation, prevent dementia, lower your risk of diabetes. Like, it's amazing. There's been starting to be things written about the potential role of not eating enough fiber and worse COVID outcomes. Bad COVID outcomes are raging inflammation. So fiber is anti-inflammatory. But plants, fruits, vegetables, whole grains, nuts, seeds, beans, plants have an immune system just like we have an immune system. So when we eat plants, we eat their immunochemicals. These compounds that make up the immune system of the plant, there's over 100,000 of them altogether. They mix and match in countless combinations in individual plant foods to act as that plant's immune system. The way they behave is they act as anti-inflammatories, antioxidants, and help our body to detoxify itself. So if someone has a pro-inflammatory health problem, eating fruits and vegetables and whole grains, nuts, seeds, beans, and seafood Those provide anti-inflammatories. So if you're neutralizing inflammation, you're preventing it from damaging your health. But these compounds, everybody, we call them phytonutrients, and everybody's heard of them. If you've ever heard that red wine is good for you, dark chocolate is good for you, green tea is good for you. These are compounds that act as natural anti-inflammatories, antioxidants, and detoxifiers, but they don't act by themselves. So we don't have science that says, okay, pick one of those pills and take those pills of resveratrol or beta carotene. These things work synergistically together to produce an effect. And when we take dietary supplements of these compounds, among other supplements, in very high concentrations, there have been instances where the outcomes have been negative. So we can't just assume that high dose supplements are a good thing. So there is such a thing as sensible supplementation. But if I have an orange, it probably has 200 phytonutrients in it, along with vitamin C and fiber and all the other things, potassium and all those other things that are in there. There's one category of vegetables that deserve a special shout out. They're called cruciferous vegetables. Broccoli, Brussels sprouts, cauliflower, any kind of cabbage, collard greens, kale, radishes, arugula. They are very concentrated. Cruciferous vegetables are very concentrated in a phytonutrient called isocyanates, which break down into enzymes in your small intestine that then go to your liver and help to detoxify your liver. So fruits and vegetables, they do act as medicine. It's just not as sexy as do this extreme diet, and it takes more work than take this pill. And I know that that's the challenge. But, you know, again, I always encourage people to start with one thing. It feels like as slow as a snail to pick one thing to focus on and get good at that, and then pick another thing, and then get good at that, and that pick another thing, with an idea of accruing some diet and lifestyle habits that you can live with long term, not temporarily embrace until you can't stand it anymore. If you wanted to be studied to be a nutritionist, what's the best certificate? So to do what I do, it's not a certificate, it's 2 degrees. I have an undergrad degree in human nutrition from the University of Massachusetts at Amherst, and a master's degree in health education from Boston University. I also did a dietetic internship at Mount Auburn Hospital in Cambridge, Mass. for a year after doing my undergrad before going to graduate school, so that I could then sit and become a registered dietitian by taking a board exam. Certificates in nutrition are not the same thing. I didn't realize until I was practicing for several years why I had to take seven semesters of chemistry, so that I could understand the human body, and I could understand when I read something online that didn't make sense, that I understood why that makes no sense. So if somebody's really interested in becoming a dietitian, I would encourage them to go to a university, get a degree. The unfortunate part is they're now requiring master's degrees. I got a master's degree before I had my kids because I just knew it would be hard to do afterwards, which definitely adds a layer. It's a whole other conversation. Is it okay safe to take Olbasitol in addition to metformin? Yes, it is. I was actually just reading a study that was a study of a bunch of studies that actually concluded that inositol was more effective than metformin at instituting regular menstrual cycles. So to take both of them covers a lot of bases, because inositol and metformin both address insulin resistance, but going after different mechanisms involved. So I would say definitely yes, it's fine. I'm not an expert in hair removal. So limiting hair growth, anything that you do to manage insulin resistance, in theory, should have some impact on hair growth. I'm not saying it's going to fix it, but if someone has higher than perfect levels of insulin, that's because it's mostly muscle cells and liver cells and fat cells have insulin resistance. But other cells in the body are really sensitive to the effects of insulin, and that includes the cells that line those follicles that the eggs are maturing in. They're called theca cells, and when theca cells are touched by too much insulin, they increase their production of testosterone, which is what contributes to the hair growth. So the diet and lifestyle thing may help. I'm not saying it's going to fix it. Just what I know from just being in this world, Laser is good for women with darker hair, not good for women with lighter hair. Electrolysis is effective. In fact, sometimes I've read stuff to suggest some women may miss a PCOS diagnosis because if they get asked, do you have abnormal hair growth, they kind of forget that they had electrolysis and got rid of it. But I actually have a patient, Dana Farber, who was diagnosed. She said, I don't know if you've ever heard of this. She said, I had Stein-Leventhal syndrome back in the 70s. She obviously had PCOS. And what she did, she said the hair growth was crazy. If one is newly diagnosed with PCOS, who should they have in their team to help them? A nutritionist? Yeah, I would say all those people. I'm just going to go to this Q&A thing. Okay. If you have PCOS and BRCA1 positive, is there a way to treat one without adding the chances of getting the cancer? Yeah, so the BRCA1 gene can increase your risk of breast cancer and ovarian cancer. But again, what goes on with your ovaries is a manifestation of the hormone imbalances in PCOS. The ovaries are not causing the problem. So I don't know of any connection between BRCA1 gene and PCOS. I think if somebody has that gene, they should get some very good advice from an oncologist about what to do about that. And sometimes it involves, trying to, do the fertility thing before making another move to deal with the BRCA gene. Is kimchi safe to eat during pregnancy? Yes. I'm sure they eat it all the time in Asian countries. You mentioned A1C doesn't always indicate insulin resistance, but that other tests aren't reliable. What's the best test to actually find out if you have? So let me clarify that because I probably said it really fast. Some scientists believe the best way to determine whether somebody has prediabetes is an oral glucose tolerance test. But those don't get used a lot because they're a lot bigger deal to do. So having a fasting glucose level that's over 100. So if you have a fast means you don't eat for 8 to 10 hours, and then you have your blood sugar tested. Ideally, your blood sugar would be 99 or less. If it's between 100 and 124, it's considered prediabetes. 125, it would have to be 126 or higher to be considered diabetes. With the hemoglobin A1C, 5.6 or lower is considered normal. 5.7 to 6.4 is considered prediabetes. 6.5 or higher is considered diabetes. So the real concerns, again, I'm just talking about one study that kind of did that on a bunch of people. And they found that any of those methods were going to tell somebody whether they had diabetes. The question was, were any of those more sensitive than any others for telling you whether somebody had prediabetes? And it seems like the oral glucose tolerance test was the most sensitive to that. However, it's the least accessible. So I would just, whenever you have a physical, ask to have a fasting glucose test and a hemoglobin A1C, and that's likely to cover you fine. Do I encourage blood sugar monitoring? I don't, because I do believe there's such a thing as too much information that could make people kind of nuts. And this technology is easily available for people that don't mind paying for it. I'm not saying that it might not be beneficial for niche situations. However, the criteria we have for kind of good blood sugar control is for people with diabetes, not for normal people, not for prediabetes. So we could make some assumptions. I've read that in people who do not have diabetes, no matter what they eat, their blood sugar probably won't go above 140 at peak before it starts to come down. But there is such a thing as exposing yourself to too much information that could become just one more stressor. So I generally don't, as a rule. There might be kind of niche situations that it might be helpful to people. As a nutritionist, do you ever offer patients a cooking from scratch and your patients a cooking to help them open up that? Okay, as a nutritionist, do you ever offer your patients a cooking from scratch in a healthy way? I'm not sure what that is. To help open up options meaning like cooking classes, I'm assuming. I don't personally do that kind of thing. I think it's an awesome idea. I think if people have an opportunity to take a healthy cooking class, through a community ed or a culinary school or something, I think it'd be great. I've come to really appreciate healthy meal kits, because I consider them like tutorials to help people learn how to prepare healthy meals. Things like, HelloFresh and Blue Apron and Sunbasket, some of these ones that are offer healthy options, because I think it can empower people to realize that, healthy food can, nutritious food can taste good. It can help people feel more confident multiple times, it can help people feel more confident. If you do it enough times, you may eventually say, you know what, I can make that without buying a meal kit a little cheaper. So they can provide opportunities to expose yourself to something different. Okay, I've seen Hillary multiple times for years for help with PCOS, and I always learn something new, including today. Highly encourage seeing her if you need her. Thank you, Maggie. Super sweet. Is it possible, do we need to make an appointment with you separately, or do you have a patient getting IVF through Boston IVF? No, you don't have to be a patient through Boston IVF to qualify. The limitation I have is that I do work part-time at Dana-Farber, so my private practice is part-time, so my access is tight. So there's often a bit of a wait to get in to see me. Robin at the Wellness Center is phenomenal about if people say they make an appointment and they want to be moved up, if I get a cancellation, she's excellent about doing that. The caveat is I'm 100% virtual at this point, and I don't see that changing anytime soon, because most of my patients are women in their reproductive years, and they really like the convenience of the telemedicine. And I'm only licensed in the state of Massachusetts. I can also see patients in New Hampshire, but different states have different licensing laws. So for example, Maine and Rhode Island are what we call red states. It's illegal to practice telemedicine in patients who were physically in those states. So if somebody was from one of those states and they came and visited their mother who lives in Massachusetts and they're physically in my state, I can do telemedicine with them, but I can't do telemedicine with somebody who's in Maine or Rhode Island. So those are the two states in New England that are red states that it's actually illegal to do telemedicine when you're in those states. An OBGYN said that I'm at risk of getting gestational diabetes if I get pregnant because I have fasting glucose level 91 and because I'm 41. She also said I'm at risk of getting preeclampsia because I have a cholesterol of 200. Yeah, so just getting older makes women at higher risk of pregnancy complications. So insulin resistance is kind of this umbrella condition under which you have a number of different health problems. So we already talked about type 2 diabetes, PCOS. There's this other condition called metabolic syndrome that's under that umbrella. The alcoholic fatty liver disease is under that umbrella of insulin resistance, as is gestational diabetes, as is some elements of preeclampsia and pregnancy-induced hypertension. So when she's looking at cholesterol levels, I can't specifically say in your situation because I don't know like all of the factors that she's taking into account. When doctors look at blood tests, including cholesterol levels and blood pressure and weight and all of that and age, they're kind of plugging them into a kind of a risk factor estimator in their head. And what I would say is the things that you do to manage insulin resistance are going to be good for all of those things. Fasting glucose of 91, I'm kind of a little surprised that they have a concern about that, but I don't know exactly what the situation is. What else beyond what was covered today is in your book? Should we choose to buy it? So in the book is broken down into 3 different parts. Excuse me. Basically, the first third of the book educates the reader about PCOS. The middle part of the book outlines exactly how to do this balanced plate approach, this kind of Mediterranean diet on a plate. There's also a chapter in there about counting carbohydrates for people that like to have a sense of how many grams of carbohydrate am I eating at once, either by looking at food labels. I have the diabetes exchange list for meal planning in there, which tells you portion sizes of carbohydrate containing foods and what size portion equals a serving of carbohydrates, which is 15 grams of carbohydrate. So if my suggestion is between 30 and 60 grams of carbohydrate per meal, that is 2 to 4 carbohydrate choices, depending upon what somebody's calorie needs are. So this would tell you, here's all the carbohydrate containing foods. Here's the portion that's equal to 15 grams. People also can use that information. There's a lot of people using nutrition logging apps and get data on carbohydrates. And so that information can be useful on that front. But the whole last part is pulling it all together. So I have sample breakfast, sample lunches, sample dinners, along with the total carbohydrate count of each of those meals. I have a page and a half of lists of snacks with protein. I have sample meal plans at 3 days at 4 different calorie levels to give people ideas of different foods that they could eat based on whatever calorie level they were aiming for. And I have a lot of resources that go beyond on other kind of evidence-based resources. I've done 2 IVF cycles, but wasn't able to get pregnant. One of the circles had twins, but was oh, I'm sorry to hear that. Yep, fertility treatment is a really super. I mean, I know Ali Domar, who's very well-known psychologist in the field of women's health and fertility, told me years ago that research she did earlier in her career, where they did psychological profiles of women diagnosed with infertility, HIV, breast cancer, and heart disease. She said that the psychological profiles, you could lie them right on top of each other. They were so similar, meaning they were equally distressing. Fertility treatment was up with those other conditions in terms of the level of stress that it can inflict. And I can totally appreciate that. I feel blessed that I was able to go on and have more children, but did spend a year of not having it happen and got a taste of it. So it's brutal. And, you know, anything that you can do to participate in self-care around these really complex issues. You know, a therapist experienced in fertility challenges like the people that we have at the wellness center can be invaluable. Thank you for doing this. I've learned so much and I have a better understanding of PCOS. I was diagnosed with this as a child and as an adult. People don't understand it. I'm very glad you also tossed upon the emotional side. I know I have more knowledge, but I can share with people so they can understand me. Great. One thing I would definitely encourage people to do is to not settle for clinical care that is not listening to you. This is one of my pet peeves. In fact, I'm participating in some training with medical students at Harvard Medical School in September around how to listen to patients talk about their health concerns. Because I know many women with PCOS go into a doctor's office and the doctor looks at their weight and they don't listen to what they're saying beyond that. And like I said, I've literally helped women develop a script, like a piece of paper that they go into the office with, copy for them, a copy for the doctor, and says, listen, I just did this the other day with one of my postmenopausal women with PCOS who has a concern about her heart. And she, you know, she's a big bone gal. She eats great. She's metabolically healthy. Her blood pressure, blood sugar, cholesterol is all good. She just on the BMI scale weighs more than the charts say she should. And we spent a lot of our session talking about how to just go into the doctor's office and address the elephant in the room and say, you know, I understand that you're looking at my weight. It doesn't tell, somebody's weight does not tell anybody anything about the quality of their diet, their body composition, whether they're active or not, whether they eat fruits and vegetables, whether they get enough sleep. And the fact that so much focus goes on that one parameter just makes me nuts, because it becomes the thing against which everything else gets measured, which again, I think can really prevent people from appreciating just how much better you can feel in your body, and like just how just like our body will tell us in a negative way when it doesn't like what we're doing, our body also gives us a lot of feedback when it likes what we're doing with our diet, our activity, our sleep, our socialization, you know, all those things that are so important. But the weight issue often just sucks all the energy out of the room. All right, it looks like we're all set. Thanks everybody for coming. Have a good night.